Our next speaker is a true champion for the TANGO2 community. Dr. Christina Miyake is a pediatric cardiologist and electrophysiologist, as well as director of the cardiovascular genetics arrhythmia program at Baylor College of Medicine. Since the inception of the TANGO2 natural history study, she has played a pivotal role in advancing our understanding of TANGO2 deficiency disorder through clinical care, translational research, and close partnership with patients and families. Her work is driven by a commitment to improving disease management, advancing treatment options, enhancing outcomes, and ultimately helping to find a cure. Dr. Miyake also serves as a valued member of the TANGO2 Research Foundation's Scientific Advisory Board. Please join me in welcoming Dr. Christina Miyake.
All right, good morning, everyone. And thank you so much for that introduction. And I love those words, the roadmap to where we need to go. I'm going to set my timer because I realize I'm between you and lunch, and we're starting a little bit behind. So today we're going to talk about the title's Observation to Impact. So this is the 4th year. So let's take some of the data and see where it's taken us over the years. And always I like to start by talking about my very first family in 2014, who unfortunately lost 2 of their children before we made the diagnosis. And really, this came as a collaborative effort with Dr. Leilani, who really I want to give credit for in terms of the gene discovery, but it's been a wonderful collaboration since. And it's been 10 years since we initially published that gene. And I want to put that into perspective. I know we all want answers and we're looking for the curative treatment, but this is how long it took. I just kind of Googled a few diseases and look how long it took. So we're 10 years in, and I think we've come in a remarkable long way in just such a short amount of time. Okay, so, and none of this would be possible without Mike and Kasha Morris, Ryan, and so many others, and Dina, the entire board, all of you. And really, it comes back, I always say this to the families. I'm standing up here, but I wouldn't be here being able to even give this talk without you. Through the Research Foundation, and all of their support. And again, I'm going to start with this because I think I put up the slide saying I want us to reach that summit. But I think in order for us to reach it, the way that we're going to do it and the pace with which we will be able to do that really depends on understanding more about the pathways you have all traveled, and that's what we need to change the course of the future. To change the course, as you've already heard, we need the information to go to those clinical trials, to have the outcomes data, to have an understanding of what our children, our adults are facing, and if they are improving or not. So if we take kind of where we started back in 2016, we were down here. We're not at the summit yet, but we're getting there. We're climbing. And I'm really looking forward to this day. But again, I think this data is really what we need to kind of get there, to get that curative therapy. And again, it really comes down to natural history studies to be able to understand who the TANGO2 individuals are, what's the natural course of their disease, what's changing it, and how is it changing it, and how are they responding. This is what's going to be needed as we go into potential clinical trials or other hopeful curative treatments that many of the basic scientists here are working on so diligently. I just wanted to give a shout out. This is the clinical team at Baylor College that's been part of the natural history study, as well as the translational team on the bottom, the scientists working in conjunction. You see a lot of different members. In addition to past members who put a lot of effort into this, and some individuals, I wish I could put all of your pictures on, but these are just some of the individuals that have taken some of the information from the natural history study participants, or perhaps some of our cells or our mouse models, and are working. And Dr. Beach is on there because she helps me with the TANGO2 hotline when I go on vacation. So these are the faces of our warriors. These are where they are located. And to date, we have 138 participants, 106 families, 22 countries. And if you look over the years, this is how we've grown. In 2019, we started with just 22 from 6 countries. This is in 2024, 105 enrolled. And today we have 138 from 105 families. Now, the truth is, my goal is always 30 new participants per year. So in my mind, I'm personally a little behind, but my hope is by the time maybe next conference, we're going to meet that goal. Of the 138 enrollees, 115 have completed their first interviews, and I want to point this group out because this is where the data is truly coming from. There are about almost 20% that still have not completed that data, so my hope is they will, and we'll have a lot more information to share in these slides. But again, the data that you're seeing is coming from these 115 participants, so thank you so much for your data. So we're going to start with just talking about how common is TANGO2. And how many people are carriers? You already heard Donna talk a little bit. This is data from the Broad Institute that was started by Seema Leilani's grant to CZI, the Chan Zuckerberg. And if you look at data, you're going to see previous and new. Previous is data that we had. A new paper is coming out any day now. And so the new data is their new estimates. So if we look at previous data, it was approximately 1 in 400 or about 1 in 300 in non-Hispanic, non-Finnish Europeans. But that number is actually estimated to be higher. So there's less carriers out there. And the Broad Institute estimated that it was previously about 1 in a million, and now it's 1 in 1.4 million. I'm going to tell you that that doesn't sit right with me. I actually think the numbers are higher than that. And so I would say, again, these are estimates. As more individuals are identified, I personally think that number is going to go up. And that's just personal experience in terms of working with rare populations that are 1 in 1 million. I have a lot more TANGO2 patients in my clinic. So here's the estimates. If you look by total numbers, we've gone from greater than 8,000 worldwide to greater than 6,000 worldwide. But again, that doesn't include the 22q11 population. So thank you, Donna, for your work, because I think that's very helpful to us to understand that we're missing an entire cohort of TANGO2 warriors. All right, so who are the individuals, those 115, and where are we getting our information? Because these are the ones that are telling us, what are the symptoms? Do I go to the ER? What happens in crisis? How should we treat? What vitamins should be given? Is it okay to give anesthesia? And what dose should be given? So this is where our data is coming from. These 115 individuals, 98 are living and 17 are angels. They come from 100 families, 18 countries, and majority are non-Hispanic white. And the second category is Hispanic. These are the countries that are participating. As you can see, we've got a nice range now of participants, mostly from the United States. And we now have 34, among the 115, we have 34 different TANGO2 genetic variants. 4 of them are new since my last talk. And if you look, we now have, comparing 2024 to 2026, we have 34 different genetic combinations. A majority are going to be, if you look, this is the exon 3 to 9 is our most common. So 40% almost are homozygous, meaning they have a double hit of that gene. Almost 70% have at least one exon 3 to 9, and 5% of our study population is 22q. These are the ages of the participants at the first interview. So this is, right now, we are predominantly retrospective. So this is the data is coming from this age range. What I want to point out is that in the last 2 years, we have new participants that have enrolled that are in their 40s to 60s. Talk about natural history study. Imagine this is where we're going to get a lot of our information from. So it's fantastic that they enrolled. These are the comparison of the ages at the time of their first interview in blue and where they are today. Now, we're still working to try to get a lot of the follow-up. 69 of those individuals gave us follow-up data, so thank you so much. So some of the follow-up data is coming from them. You can see the ages in which they gave the information. Okay, so we're going to go back. We're going to start a little bit at the beginning. I know there's a range of people that know a lot about this and some that may be new to this. So I'm going to try to kind of find that middle balance and give you a little bit of information and what we've learned. And so in the beginning, if you look at the blue bars, those are normal developmental milestones and the ages at which you are supposed to meet them. In 2024, the gray bars you can see, our data suggested that you really didn't start to have most symptoms until you got to the sitting age where we started to get some delays or crawling, so maybe over 6 months of age. But more recently, our data, if you follow the orange bars, you'll see that actually some of the symptoms are starting earlier in infancy. So that's what I'm learning, is that they can actually start earlier, even in the first 2 to 3 months, and that the delays can be much more significant. There can be people that are, children that are meeting those milestones much later than we initially thought in 2024. This is the time in which parents are reporting the first symptoms consistent with TANGO2. And so you can see that almost all are going to have symptoms before the age of 5 years, and some people are going to say they've never had a symptom. So we'll get back to that in a little bit. This is now going into the typical symptoms in health. So I'm going to compare kind of your baseline chronic kind of symptoms. Remember that these are symptoms that are more generally in your children or adults, more on a constant basis. And I want to distinguish that from the quote, the spells which can come, or paroxysmal episodes that can come and go. So we're going to focus again on the baseline symptoms. These are, you can see some of the toe walking, that stiffness, some difficulties with walking, even when you're not in a spell or crisis. New to us in the last few years is tremors. So if you put your foot down, that you're going to have like a clonus type of myoclonus or clonus reaction. And that's really, really common. If you're seeing that, don't worry. This is we're seeing that. Most people are going to say that they're seeing that. In addition, what we noticed with the natural history study is that these symptoms, these motor movements, I'm focusing on motor movement around, progress over time. And some individuals will end up wheelchair or even bedbound. If you look specifically at what you reported, 86% are able to walk. So we dove a little bit deeper into that and said, well, is it because you had a crisis before you were walking? And that definitely was the case. 33 participants had a crisis prior to walking, and 42% of them are now walking, but 33% are still not yet walking, and 15% we do not expect to learn to walk. So that crisis might put you in a state where you don't walk again, but certainly you can. So now we got to figure out, why is that? 77% can run, and 44% reported stiffness. I would have thought it's a little higher than that. But again, you can see the numbers. We tell you the numbers that responded yes to the numbers that actually we asked, because as we get more data, we have to go back and start asking the questions again. What about speech? So I'm going to give you just some snippets. I think this progresses over time. And as you're younger, you have a little more words. The speech is maybe a little clearer. It can get a little bit less clear, but I'm going to tell you that with some of the B vitamins, and you guys can, a lot of the parents are reporting, and even I've seen it in my patients, the speech can get clear a little bit over time, and they develop some more words with, and I think it's the B5 is my guess. It can get, if you don't get on those vitamins, your speech can get almost unintelligible. Now, she understands what I'm saying, and I could understand a little bit, but I can't understand most of her words. Now I want you to hear someone. So this is our 63-year-old, and I want you to listen to his speech.
The vest that you're wearing, I have my one at home that I got last year in the closet. I like to have it to wear. You know, I can wear it to lay around. It's going to be too big on me. Nothing I can do about that, but I'll wear it anyway.
All right. I don't think if you met him, you wouldn't know necessarily, right? He's got excellent speech. He had a really excellent vocabulary. I was incredibly impressed. That's me interviewing him, by the way. And we'll talk a little bit more about him, but as you can see, what a spectrum. And why is that? That's what we have to figure out. Okay, so speech delays are common. This articulation, I think, is very, very classic. And that is my key to knowing if I have a child who's got a prolonged QT in the hospital and they have perfectly clear speech, they're not TANGO2. So I think it's a key factor. Okay, what about cognition and communication? Developmental delays were really common cognitive delays in over 90%, both gross and fine motor. If I asked, can you put two words together? About 72% can, but you can see only about 50% have more than 100 words and can speak full sentences. That means that about 50% can't get to that full sentence. The median age, which at the time they reported they were able to make a full sentence, ranged from 1.5 to 10, the median age of 4. About 40% to almost 50% of those that we asked are able to read and write, but that also means 50% can't. So that's another thing that we are still kind of investigating. Again, some new reported symptoms, ADHD and autism. Now, I don't know if this is just something that is part of TANGO2 or a separate diagnosis, but this is something we need to investigate further. What about endocrine? Okay, so 54% are reporting hypothyroidism, the age at about 6 years, but it could range anywhere from early as 2 months all the way to 32 years for the first diagnosis. A vast majority have had a crisis, but not everybody, and about 26% also have seizures along with the hypothyroidism, and 21% have hypothyroidism, seizures, and have had a crisis. We then asked on the 69 participants, how many of you have a new diagnosis of hypothyroidism? And there was only one that reported hypothyroidism, but interestingly, when we went back, that was only 6 weeks after the initial interview. So if we look at farther out, I'm wondering, I don't know, I haven't seen any new hypothyroidism. Hypoglycemia, as you know, is kind of cornerstone. It can happen. It's usually in that very first unrecognized crisis. Adrenal insufficiency in one, gynecomastia in one, and this is one I want you to pay attention to, impaired testicular function. That means infertility in males. So this is a new finding in the natural history study. So here's what we are doing. We're doing a hormone workup generally between the ages of after 12 to 14. This is what we're doing in the females and in the males, and this is being led by Dr. Hoyos, our endocrinologist. So we are finding that into puberty, our older males are infertile. Now, whether or not we can prevent that or whether that's everybody, we don't know. But if you do have an endocrinologist, I would suggest you do check if your child is in the pubertal age and let us know. And this is kind of the lab values that will tell you if there's some dysfunction within certain cells. All right, another finding that's new is thyroid nodules. So thyroid nodules were found in 3 individuals. 2 were benign on pathology, 1 was malignant. Now, we don't know if this is part of TANGO2 or if this was just a one-off, but I think it warrants further investigation, and I think it's something that you should at least let your physicians know that they are finding these nodules. And there's a poster out, this is Dr. Julissa Castro's poster, and she has a poster out in the hallway if you want to hear more, and she'll tell you more about it. Let's see. Okay, so other symptoms, optic nerve issues. I know this was in our first report, but still it hasn't been as high as I thought, but it could be that we're not able to make the diagnosis, but it's 7%. Hearing loss is an up-and-coming one that I think is getting missed. Please make sure you're getting your hearing exams. 10% are reporting. Ear tubes in 17, I don't know. It seems to be pretty standard. I'm not getting a sense that it's more than typical. But this is an interesting one. 50% are reporting a really strong reaction to loud noises. They don't like it. Also, the other one on here, is pain threshold. A lot of the individuals have a very, very high pain threshold. So those of you in basic science, please put this together. The other thing that I think is important that we need to pay more attention to in the natural history study is a lot of reports of migraines and severe headaches. Some of that is associated with vomiting, and two actually got elevated opening pressures. That means they actually did a spinal tap during the headache, and they noted that there's pressure inside the fluid around the brain was elevated. So if you're a neurologist, this is something I don't know if all the other headaches are, but it may be something you want to know. Severe pain episode also was reported in one, a thalamic storm in one. So these are endocrine. Okay, so let's go into the neuro seizures. 50% have seizures. Median age is about 2, about 1 to 2, and it ranged anywhere from 2 months to a first seizure being 23 years. Most of those children have had a history of crisis rather than no crisis. And amongst those 69, 3 do have new seizures, so brand new seizures after the initial interview. 64% are on seizure medications. You can see a variety of different types of seizure, but probably the most common is that they didn't know what type. Obviously, I think a lot more work needs to be done in this area. Lastly, movement disorder. This was really hard because I don't think people knew what is a movement disorder. What do you mean by abnormal movements? I actually think it's more common than that. And I think a lot of the work that's being done by Dr. McKenzie and his group, we really appreciate all of his work in this. They are the expertise in this area. And they took some participants from the natural history study, and they should be publishing this, but basically tried to really say we can't really say things are spells. We really need to focus on identifying the exact etiology and what's the mechanism of what's going on with these movements. And so really appreciate that. And they've noticed that there's different areas that are involved, but there's a lot of overlap. So if you see down below, kind of a lot of overlap with dystonia, weakness, ataxia. And so it's not very easy. And I think as a parent, I would say what's important to us and physicians, yes, we need to be able to recognize exactly what these are, whether it's ataxia, dystonia, hypotonia, hyperreflexia, but for you might, if you don't remember all of those words, that's kind of why, whether you want to call it an episode or a spell, or sometimes you have to have one word to describe, I'm okay with that as long as you know that's not a crisis. And the spells are really more transient. They are not your everyday symptom. Dr. McKenzie and his group then took each individual, looked at when they got their diagnosis, when their symptoms started, when they started taking B vitamins, B5 in particular, and the dose they were on. And really, really good work. Again, they had limited numbers. Here's kind of my interpretation, and Dr. McKenzie can you can also look at his paper, but taking his work in putting it into the context of what I know from the other participants, here's kind of what I took out of it, is I think B5 can resolve some of the symptoms, particularly some of those transient ones in many, but it doesn't affect everybody. And I think that it has less effect on some of those baseline chronic symptoms that are present. I do think that there's some improvement, but I don't know that it completely reverses those that you see every day. Although I would love to continue the study to see if it actually can fully reverse those. Higher doses may be necessary, so he kind of looked, again, at least 50, but many of the kids were on higher doses, 500 or more, as you already saw. And that some didn't respond at all. So I think that there may be a subgroup, particularly if you've had a crisis in infancy, and you really had some regression, or you never met those milestones, that they may not, unfortunately, recover the way we want. Now, I still give it hope. I would still continue to give vitamins, but right now, at least the data is suggesting that they may not get as much recovery as those who may have been older and didn't have such a significant crisis early. Okay, so another little branch of the study was anesthetic outcomes, and Dr. Kanjia and Dr. Brandon Lee helped with this along with our team. We had 10 patients, 36 total procedures who underwent anesthesia. This really spanned from dental to imaging to really extensive surgeries, more than 8 hours long. Multiple different anesthetics were given, and really no combination made any significant difference that we could tell. Only one patient had arrhythmias, and that patient was already in a crisis at the time of anesthesia. No procedure definitively induced a metabolic crisis. No one had to get significant rapid response. There was one patient who did have an increasing CK, and we thought might be going into crisis. This patient, however, had the longest procedure and had muscle manipulation. So that can also release CK. But we learned a little bit from this. We were having a difficult time feeding that patient. And so we changed our protocol, and because we didn't think that anesthesia itself is posing risk. We think that it's more likely the risk is because how long that child is not eating before the procedure or after the procedure. So if you have a procedure and then you're kept NPO, or you've got a gut problem and you're not eating, I think that can put you into crisis, not the anesthesia itself. So we recommend, and you'll see the recommendations, the clinical that Dr. McKenzie talked about minimizing the not eating state, NPO state being the first case. If it's a long procedure, if it's really long, more than 8 hours, we are admitting some of the patients to give them some IV fluids with the vitamins beforehand and making sure that they're staying on them. But the shorter procedures, we are not. We check some lab EKG, CK, SGLT, lactate before, and then we do, if it's a long procedure, during the procedure, they call us if there's a problem with it, and then we check after, and if it's fine, they can go home. And you'll see more of those in the clinical guidelines or clinical recommendations. Okay, let's go back to these quote spells. Again, I want to say I know that we are trying to define these, but generally these are just a group of symptoms that are more transient, paroxysmal, and are worsening of often your baseline symptoms. 97% reported spells at some point in their child's life or adult life. And you can see most of them are going to occur at a median age of 16 months, but range between 4 to 6.8 years, and 4% have never reported a spell. On follow-up questionnaires, I can tell you, just like a lot of the data you're seeing today, many of the parents are reporting resolution of spells with the B vitamins. Again, if you're not, just sort of a review of spells, remember these can be head tilt, extreme lethargy, increased drooling, slurred speech, this staring off where you just are you just seem unresponsive, loss of balance, ataxia, this falling over, leaning, unable to get up. So these are triggered by illness, not eating, excessive heat, being more active, and sometimes in the morning, and I think that's sometimes related to just long time of not eating. You might see these. And this is more before the vitamins. Okay, and I think importantly, just the spell versus your chronic baseline symptoms. Again, this is a child who's in a spell. She can't get off the floor, but then you'll see that at baseline she can get up. So the spells are what the B vitamins, I think, from the natural history study, are helping the most right now. You can kind of see that lots of people are reporting balance problems, drooling, head tilts, and you see where they're worsen. Cold weather doesn't seem to make as much difference as hot weather. And constipation seems to also be, when kids are not moving their bowels, sometimes those symptoms seem to be worse. This eye wandering, I just wanted to mention, not everybody mentions it, but many people do. That's kind of that eye wandering outward, that lazy eye. 63% did. And of the 5, I just wanted to report this, that had surgery to correct it, 3 said it improved, 1 said temporarily improved, and 2 said no improvement. What I've noticed just after giving a lot of the interviews, it does seem like that eye wandering seems to get better or resolve a little bit later. It seems to be the worst in the early years, toddler, early childhood. I don't know if that's going to pan out, but that's just subjectively what I tend to hear. And I want to just report, so again, this is Robert. You can see that stiffness. He's got some of the stuff, but he can move. And then this is the spell. So again, we're not going to necessarily, I think the B vitamins are preventing a lot of this very acute onset, really severe symptoms. Okay, so that's what we're saying. Okay, so what about metabolic and cardiac crisis? What are we learning? What did we learn? I'm just going to review this real quickly. Our terminology, I call it the green, yellow, red. If you're in your baseline health and your chronic symptoms, you can go into these spells. I've already described them. There's no lab abnormalities. So in other words, if your CK is normal, but your child is having really extreme lethargy, balance, you're in a spell, not a crisis. And that crisis is important because this is a really important term, because this is where you're in a very hazardous, dangerous potential zone. This often is triggered by either illness or not eating or low vitamin intake. And this is associated with abnormal labs. So your CK is elevated, your liver enzymes might be elevated, you have an abnormal EKG. In our natural history study, we showed that about a third of these, without any intervention or treatment, they can resolve to normal. And I'll tell you, that's probably because they're eating and getting their vitamins. Those that do not eat, do not get their vitamins, are going to evolve, 2/3 of them, into a cardiac crisis. That is by definition the involvement or presence of arrhythmias, heart rhythm problems, heart failure, or both. And sadly, our data showed that that was a high risk of death. Although about 50% died, 50% did recover. And the question is, do you ever get back to your baseline health? And so that's another question we were asking, and we'll go into that. Here are the ages of the first metabolic crisis. And what I want to show you is there's one out here that is in their 60s. First crisis in their 60s. Okay. 68% have had at least one metabolic crisis. There you can see the range, 2 months to 61 years, average age around 2.9 years. 32% have never had a crisis. We have a 26-year-old that's never had a crisis. And at least based on our data, no one has had a true new crisis since starting B5 and B9. Now, there is one patient that reported an increased CK, but I'm going to tell you the circumstances were an individual that underwent a surgery, gut surgery, that didn't eat, didn't get put on vitamins, and so the CK started to rise, and I think that's the reason. Had they been given IV fluids with vitamins, I do wonder if that would have not happened. And one patient really that we found on monitoring where they started to have arrhythmias. I went back to talk to that mom, and it turns out that they discovered that they were missing getting vitamins, and it was about a 4 to 5 day window. So that gave me some information. You miss your vitamins for 4 to 5 days, and you're going to evolve into a potentially dangerous situation. All right, what about the impact, the cardiac findings? This is the first poster that was presented in 2019 talking about the heart failure and rhythm, and at that time we thought, the best option we had was isoproterenol and pacing. We also, at the time, were very concerned. Heart transplant was being performed because of the severe heart failure. But over time, what we realized, and this is my patient who had both severe heart failure and arrhythmias, that with vitamins, you completely resolve. You do not go into heart failure. You don't need a heart transplant. What an impact. So with the vitamins, we no longer, if we get the call, and we've had 2 so far for potential heart transplants, we just tell them to give vitamins, and no one has had a heart transplant since. So that's impact. Yeah. Again, this is all you, not me. Just take your data and I just spit it out. Okay, so here's another. So people ask, well, how did you figure out some of the vitamins instead of isoproterenol and pacing? Well, this is one of my patients. She went into crisis, and what you see on the bottom is her hospital day. So you can see the long hospitalization, and all of these are cardiac arrests. All of these are rhythm issues. You can see every day someone was pumping on her chest, shocking her. And then all of a sudden you see something stops. So I had to say, well, what happened at this point? But clearly it's not the medications we were giving her. Then none of that was working. So I looked in, and guess what she got started? Right there. TPN. Guess what's in TPN? B vitamins. So the other thing we noticed is that children on the infant formulation of B vitamins, which only has 200 micrograms of B9, did not recover their rhythms, but those that were on the adult formulation of 600 did. So again, that kind of clued us into maybe it was B9 because the B5 wasn't as significant, but still, again, we think that these 2 vitamins are important, particularly B9, maybe from the rhythm standpoint. Began to publish that, our impact, stated that B9 and B5 were the ones we thought were important. And I'm going to tell you, over the years, the issue that I have and comes across all the time is, how do I get my child these vitamins? They come in pills, my kid won't take them. I'm trying to buy all these different pills to try to get to your formulation. What should I do? So I worked, I think it's been about a year, I worked with a local pharmacy to create a formulation. I asked them, I want the B vitamins, but I want you to make it high in B5 and B9, and I want you to make it in small quantities because no one likes to take it. And I need a liquid because people don't like to take pills. And so they did make it. It's right here. It's the first time I'm actually seeing the bottle because it actually gets mailed out. I know some of you, some of the people are here have it. I do have 10 bottles here with me, but it is, what I like about this pharmacy is that we can manipulate that. If, let's say, the natural history study changes and we need to be on 750 or 20, we can change that, and they're willing to work with us. That's incredible to have a pharmacy that's willing to work. They can also ship around the country, at least in the US right now. The only state they can't do is California. So if you have someone in California, someone else can ship them, but they can't legally do it. So you can talk to your, if you want that number, you can talk. And we're not making any money on this. This is just, we're trying to help find solutions to people getting their vitamins. Okay, impact, TANGO2 hotline, the TANGO2 emergency hotline. This is back in the day, it was just these calls that we would get because someone knew somebody, or Cheyenne knew me, or, and so these are just the ones I remember off the top of my head. You can see a list, and unfortunately only 2 survived. One had to go on life support way back. And what's changed since then? Well, thanks to the TANGO2 Research Foundation for supporting this hotline and allowing us to have it. There's the number physicians can call. We started to keep track of it, so this is not all of it, but since we started keeping track, 25 calls, this is probably in the last year, 114 texts. So once I call, we're texting back and forth, trying to help management. And at least, and of these, there were 5 life-threatening crisis events, and every single one of them, I'm proud to say, survived. So I think that's impact. And again, I'm going to tell you, the data is coming from the natural history study. Okay. So another story. Okay, so sometimes I get invited to give talks around the world, and this is one. It's called PD Rhythm. It's a world event. And most of my colleagues say, TANGO2, I am never going to see that disease. I'm going to tell you, I prove a lot of them wrong. At that conference was a very, very well-known Dr. Arthur Wilde from Amsterdam, and then our very own Dr. Tisma, who's here today, sitting right there. She was listening, and she's probably said the same thing, but she's a good listener. So Connor Gillette, I know his mom will let me share his story. He's an amazing warrior. Saturday, June 7th, 2025, he was admitted for new seizures. He has 22q1 deletion syndrome, and they didn't understand why he was having rhabdomyolysis, meaning elevated CK. It kept rising. They couldn't get rid of it. Obviously, you all know he was in a crisis. He then went in the morning into this lethal heart rhythm called torsade de pointe. This is incredibly lethal. On the way to moving him to the cardiac ICU, the EKG showed a prolonged QT. All of you know that is our marker. And Dr. Tisma was on call. She sees this. As he's being moved over the cardiac or the intensive care unit, every 2 to 3 seconds, he's having an abnormal heartbeat that was putting his life at risk. Now, the standard management for this is very typical. This is what all electrophysiologists are going to do if they see this combination. They're going to give you esmol, lidocaine, magnesium, shock, but thank you very much, Dr. Tisma, for paying attention to that lecture. She didn't do that. She called the hotline. And based on the data that's come out, Wei Zhu is here, and Lily Zhang and some of our team, we did some studies in taking patient cells and with TANGO2 deficiency, and we noticed that B9, but not B5, corrected their arrhythmias. Based on that, when Dr. Tisma gave me that call, I told her, don't give any antiarrhythmics, because we know that number one, they don't work, and sometimes they make things worse. Give vitamins. Give folate. And I'm going to tell you that no physician probably would have listened to me, but she did. She did, and she gave it, and within 10 minutes, the rhythm all completely disappeared. 10 minutes. So this is Connor getting better. Within probably 48 hours, he was already getting better. And this is him. What a warrior, right? Yes. What a warrior. But honestly, thank you to Dr. Tisma for saving his life. Taking that chance to do something that most physicians aren't going to do. What? Take a treatment that is standard protocol and don't give it at all and give a vitamin? That's incredible. So thank you to her. I think she's also changing the way we are managing now, because for the first time we know that we can potentially reverse this with vitamins. All right. So I think this is a big question, right? How do crisis events and vitamins affect outcomes and symptoms? You already heard a wonderful talk by Dr. Bose. Thank you so much for your incredible work. So you saw a little bit of this developmental profile 4. So this is a tool. It's a questionnaire. It takes about 15 to 20 minutes. And it asks a series of questions, and then it compares your answers to age-matched peers, and compares you to age-matched peers in 5 different abilities: physical, adaptive behavior, social, emotional, cognitive, and communication. And then it takes and gives you a general developmental score, and then you can kind of see the scores that you need to be above, about 85 or above to be average, and then below average and delayed. So let's look at our TANGO2. So here's 54 participants. What you'll see is that, unfortunately, most, they are in that delayed range, with the most common really being in that physical area. 60% are delayed. However, look, 40% are of average or above average in social emotional. And I don't think you as parents are going to be surprised. But now let's go and look kind of a little bit. So social emotional, by the way, is interpersonal skills. It's your understanding, it's your functioning in social situations, and how they relate to peers and adults. So what we did is we kind of mapped this, and I'm going to tell you it was all over the board. I mean, these numbers were everywhere. But I thought, my hypothesis was that it might have something to do with the vitamins. So what I did is I broke it down into when you first started your vitamins. So you can see that the infants that started vitamins are really in that normal range. Here's average is the red, and then delayed. You can see some people are in this average range, but it really varies. So then what we did is we took it and we said, well, does it matter whether you've had a crisis? And indeed, it does look like your median scores, that's that blue, that dark bar, is higher if you haven't had a crisis, with higher people up here, versus the green if you've had a crisis. So same age, no crisis, crisis, no crisis, crisis. And this is your overall score. In particular, look at this person. This one has never been on vitamins, but is way up here. We're going to talk about that individual in a bit. All right. So again, it kind of across the board, if you look at physical scores, again, here you're telling this is large and small muscle coordination, strength, stamina, sequential motor skills. Again, you can kind of see the difference between the no crisis and crisis, where the bar is for delayed or average. And then you can see adaptive behavior is your ability to cope independently in the environment, to eat, dress, work, use technology, and take care of self. I think this was our highest scoring among our TDD patients, is social emotional, which you've already seen. And cognitive is a little bit lower, and this is academic achievement. But again, there's a difference whether you've had a crisis or not, no crisis. And then here's communication. So your expressive and receptive communication skills, including written, spoken, and language using gestures. All right, so then 9 participants gave us follow-up data. So that was the first interview. Now we want to know, do you grow? Do you get better, or do you get worse over time? Does it matter if you have vitamins? Fortunately, I only have 9 participants, but here's what, most of them stayed about the same. So you can see this is the same. So they're delayed, below average, below average. But I'm going to tell you that in here, I'm going to point out Ryan Morris is one of these that didn't change. But if you look at his individual scores within each, he does shift in social emotional. He goes up in every area, and that's that growth score. So we can actually then go and look at, how are you growing? Are you improving? And I think we can continue to look at that in each of your individual children or adults to see, and then we can compare it to vitamins. But obviously, as you know, we're going to need more than 9 people. But I think this is important too, because 2 people went down. So we need to figure out, why did they go down? They were some of our older individuals, but we need to figure that out. And I love this one. Someone went from delayed to below average. So they're going up. And this is in the entire score. That's a big difference. And so I think this is where next we need to really look, because this is more objective kind of data. All right, why is there such variability in symptoms? I think all of you know, and you've seen many papers, but you've got this is Seth. He is walking completely normally, very fluid. He can do activities. This is someone who's probably more, I would say, more mildly affected. And then you've got someone who's a bit more moderate to severe. And then you've got someone who's really severe who can't walk. So why is that? So we kind of came down and I was thinking, could it be age? Well, no, because I've got older people who can walk and I've got younger people who can't. So it's not age, it's not progression. Is it crisis? Well, definitely crisis has some effect for sure. You've already seen that physical score, but it wasn't the only answer because I have kids who can't walk or can walk who haven't had a crisis. And so I didn't think that was the exact answer. Is it genetics? Well, let's look at that. In the natural history study, it's our siblings that are helping us out with this. So you can see on the left in each one is going to be a sibling that has had a crisis, and on the right is a sibling with the identical genetics who took vitamins early in infancy, and you'll be able to see that there is a difference between the individual who took the vitamins. So I don't think that the answer is genetics. If you don't believe me, let's take a look a little bit farther. I'm going to say thank you. This is that 63-year-old. His name is James or Jim McNally. And this is him. This is me interviewing him, and this is him more recently. So let's go through his story. I'm going to go. So he was born in 1963, and at age 2, he started to develop his first TDD symptoms. In childhood, he had similar difficulty walking, tripping, falling. But guess what came out in 1968? And his mom bought them. And he took them, and for some time, we don't know exactly, but they think probably into either early to late high school. And guess what? He graduated. He can drive. He got a job. Now, he does have some learning difficulties, so he's in a special program, but he lives on his own. But then, what happened? At age 62, he had his very first crisis. Now, what in the world happened between that and how does a 62-year-old have his first crisis? That's what I wanted to know. So when I interviewed him, his mom is no longer alive, unfortunately. This is what I wanted to know. And here's what I think. So when I interviewed her, his mother played a key role. She apparently cooked every night. They sat down at the table every night, and she cooked a meal that was protein and then a vegetable and then some starch, but there was always a vegetable and always a protein on there. And he ate, he had to eat, and he was a very, very good eater. In fact, you can see he ate a lot. He may have eaten his dose and vitamins, but he was a very good eater. But regardless, his mom made him finish. She was that was very important. And then in addition, he started to have some symptoms. But guess what? At age 53, when I asked, when did you start to have these spell-like symptoms? He said around this age. And I asked what was going on. So we went through the timeline. Turns out his mother was getting older, was cooking less. So he was starting to cook, so he can cook. But he cooked different things than his mom did. And that's when they started to notice the symptoms. But then started to have some spells. Then at age 60, his mother entered a nursing home. And guess what? He was on his own. And when I asked what was he eating, Mountain Dew was his favorite, cookies, chips, that was his diet. So is anyone surprised now? Do we think, I think that this is a key, this is what happened. All right, I am going to try to go. Are you okay if I go like 2 minutes, or you want me to stop because it's 47 now? I mean, okay, all right. So this is another, if you don't believe me, because Jim McNally does have a unique variant, so maybe it's his genetics. Okay? I'm going to give you another one. This is the Zacharias family. They just enrolled in November 2025, and we just completed the interview 6 weeks ago. But they have exon 3 to 9 deletion, what most of the majority of our TANGO2 community has. A paper was actually written about them, variable clinical severity in TANGO2, and how different people can have. And oh my goodness, is this, what's going on? Is it the genetics? And they talk about there being a single family with the same gene but different symptoms. So here we go. Let's start. 4 are affected with TANGO2. Again, at the typical exon 3 to 9. Their first one had a crisis at 6 months and unfortunately passed away. The second child, again, had a crisis in infancy. She survived. She got a G-tube, was being fed formula, so you can guess why she survived, I think. But unfortunately, she has not recovered. She's non-communicative and bedbound. So then comes along their youngest child who's affected, and she's 9 years old right now. She was diagnosed at age 3 at her first crisis. She had her second crisis and third crisis at 5, and then last fall. But all crises happen when she travels to Mexico. She goes out of the United States and she travels. Thankfully, the third crisis, she made it back to the United States, and they called the TANGO2 hotline, so we got involved with the family. And at the time, so she recovered, she's doing great, but we found out that she has a brother who has no symptoms. He is able to drive, he graduated from high school, he's got a girlfriend, and he's trying to start a family. So then, obviously, why are these two different, right? So that was the next natural history study. So he can read. I don't know if you can hear him, but he's actually reading. I'll kind of go. But anyways, he can read. She has more of a speech delay articulation problem than he does.
Animals, large and small, depend on one another to survive.
So you can see, I do think he's got a little bit of articulation. You can't hear, but he can clearly read. He can clearly read some big words. And I asked, how many, do you remember last time did I ask you guys to send me a picture of what you guys were eating? Anyone remember that? Okay. Unfortunately, I didn't get any pictures, but I asked this family, just randomly, the day I said, can you just send me a picture of what they're eating? Look at what they sent me. Now, they told me that Jesus does not like vegetables, but Mom says she cooks every night and she hides vegetables in everything. And he says he doesn't eat it, but look at that plate. That is full of B5 and B9. It is eggs with spinach. Her diet is completely different. She's eating mac and cheese. No B5 in there. And then if you look, this is on the girl. She does not eat meat. She doesn't like vegetables. She's a very picky eater. Her favorite foods are white rice, potatoes, and beans. She eats cereal and pancakes. And their crisis occurs when they travel to Mexico. Now, I'm still trying to figure this out, like whether is there the B9 or B, something's going on where I think her diet changes. So we're going to figure that out. But this is the age of the participants at the time of the last update. Obviously, we are learning so much from each participant that enrolls. In my conclusions, I think B5 and B9 continue to be important vitamins, at least for now. The B vitamins improve symptoms probably more on the transient than some of your chronic baseline, but not all respond, and it may be related to significant impairments that occur early after an early crisis. The spectrum of symptoms may include thyroid nodules, cystic infertility, severe migraines, headaches with elevated opening pressures. The diet, this is the key. I think diet appears to play more of an important role than we previously thought. And in addition to the vitamins, we may need to put more emphasis on what our warriors are eating. Vitamins can be obtained through diet alone, but data suggests it requires an individual who eats large amounts, is not a picky eater, and eats a balanced diet that includes meats and vegetables. So if you're still having those spells and you're getting your vitamins, maybe think about what is your child also eating? Like maybe we need to work on both ends. And if your child is vomiting or they're not eating as much, but they're getting their vitamins and they're still not getting out of it, maybe we need to focus more on the food that they're actually eating. So I'm going to leave it at that, and hopefully in 2 years, I'll have more information for you.